Today, I'd like to talk about hypertension and diabetes in the African Americans in an urban setting, specifically low-income African Americans. I pulled my quantitative data from the 46616, 46601, and 46628 area codes in South Bend. The reason being is the clinic that I just spent 2 semesters in is in one of those area codes. I also grew up in one of the neighborhoods in one of those zip codes, and the hospital I work for is also in one of those zip codes. So African Americans make up 26% of the population of all of South Bend, but in 46601, African Americans make up greater than 50% of that population. The median household income in that zip code is less than $25,000 a year. This data is a couple of years old. I will give you 24.4% of African Americans are living below the poverty line. The majority of low-income African American families live in those area codes that I just talked about. This is national data. African Americans are more likely to suffer from hypertension than whites. So about 1,000 in 100,000 will die each year from heart disease. Cardiovascular disease being the leading cause of death of African Americans and whites as well. But as we know, African Americans kind of bear more of that burden than their white counterparts. African Americans are more likely to have diabetes as well. And the rates range from 4 to 9%. That 4 to 9%, as African Americans and whites age, that it gets higher. So like a 65-year-old, there'd be 9% more African Americans would have diabetes than whites. Diabetes costs, you can just kind of read here, but there's huge cost for diabetes and hypertension to this country, and it costs more for African Americans per year than whites to manage diabetes, and Hispanics as well. And you can see the deaths there. So there's a huge cost in both dollars and lives. Windshield survey, I'm just going to run through this real quick. Again, this is a neighborhood that I am extremely familiar with, having worked in it for many, many years and growing up in one of these neighborhoods. I will say it's a lot of single-family homes. There are some duplexes, a few apartment complexes, but not apartment complexes like I think most of us know of. I'm talking like one building with like anywhere from like 4 to 10 maybe at most units in it. Most of the houses and these apartments are fairly run down, potholes in the streets, like lots of things in the yard. There is a hospital, like I said, in this area. There are at least 4 clinics, and at least 1 or 2 of them are free. HealthLink actually has a clinic right next to the hospital. There are several homeless resources in downtown. There's a homeless shelter. There's a few others in downtown South Bend as well, and a mental health hospital as well in downtown South Bend. Like I already kind of covered the environmental, social functioning. The neighborhood associations, the Near Northwest Neighborhood Association is kind of one of the biggest ones in this area. It's been revitalizing the neighborhoods for close to 20 years now, taking old homes, fixing them up, and selling them at an affordable cost. At least what I feel to be an affordable cost. But again, I make more money than probably the population I'm speaking to. But they are working on really kind of bringing a lot of these neighborhoods back, working on kind of decreasing crime in the Near Northwest Side neighborhood. They also do a farmer's market on Saturdays. I haven't seen it set up yet this year, I think, with everything going on, but they've done a lot of good things. Like I said, predominantly I'm focusing on low-income African Americans. There are a lot of single-parent homes. I kind of this data I was able really kind of took for more of anecdotal, just working in the clinic with the patients that I've worked with. There is a high crime rate. You can just look that up on the internet. A lot of shootings, a lot of break-ins, cars being stolen, things like that. Like I said before, African Americans are more affected by hypertension and diabetes than any other races. And even more so at lower socioeconomic areas. Fewer resources for the lower socioeconomic classes, and there's a high morbidity mortality rate from cardiovascular disease in African Americans. it still being the leading cause, and that cardiovascular disease stemming from hypertension, diabetes. Some of the research articles I pulled talked about poor minorities in disadvantaged neighborhoods having a higher rate of CVD. And what it looked at was taking different neighborhoods and kind of grading them from bad to worse type of a situation. And then over an 11-year period, looking at following these people along, and they found that the people that were in the worser neighborhoods had a higher rate of CVD. And I think we kind of all can say, we've learned so much about this, the stress of living in these things, in these constant state of stress, causing so much havoc on the body, causing hypertension, causing diabetes, causing things like that, heart attacks. Less access to healthy environments and foods, so like less green spaces, less healthy foods like supermarkets, things like that, more like the convenience stores, which the areas that I'm talking about lack supermarkets almost completely. There's one on the north end, but really everything else is just the little mini marts. Minorities may have, excuse me, distrust of the healthcare system, and there's been several articles that have kind of talked to this. One article that I pulled talked about using community-based healthcare workers. So like not nurses, maybe not even like social workers, but just people from the community, from these areas, that are being trained to like help be the liaison in between a healthcare worker and the patient, helping guide the healthcare system, helping do education, things like that a lot of providers just don't have time for, or may not know how to speak to somebody from this community, given that a lot of our healthcare providers are white, or we do have a lot of Middle Eastern in this community, but very few Black healthcare providers. Healthcare education done by outsiders, so that's kind of what I was just saying. So the community-based healthcare workers kind of handling that part of it. And then another article I pulled talked about using churches and community centers and things like that for doing point of care, blood pressures, hemoglobin A1Cs, HIV testing, just to kind of get these diseases early, so when we can actually manage them and maybe reverse some of them, and they won't cause long-term untold damage, or be spread to several other people. So catch them early, when we can, before symptoms really kind of start to poke up. So like I said, early disease identification, employ community healthcare workers at the front line to navigate the system, educate, policy changes, in that having supermarkets that can supply healthy foods at a reasonable cost. It costs so much to eat healthy, in our society. Policy change to make affordable living an option in a safe environment, and then also talking about a lot of these houses. There's one data set where I pulled where a lot of the people in these areas were actually renters. You're renting these houses that are like run down. So you gotta worry about what's going on in these houses, carbon monoxide, mold, dust, bugs, everything like that are just causing more and more health problems. So more regulation on the people that rent these homes out. So for my individual level, so the standard care, like you're looking at the early identification, work with community leaders, schools, things like that. Your ADA guidelines for diabetes management, looking at metformin, weight loss, healthy diet, getting that hemoglobin A1C down. JNCA guidelines for blood pressure management, specifically in the African American population. How would I provide care? So identify insurance status, one way or the other, and work on hooking these people up with somebody to get them the insurance, the coverage that they need, so they can actually afford medications, tests, anything that they need. It amazed me at like how many patients that we saw that didn't have insurance, not even um, Medicaid. So assess the living situation. So talk to them like, what do you live in? Where are you living? Or how are you heating your home? There's one patient I talked to, just kind of talking to him, kind of find out he's heating his home with his stove, which, I never grew up with that. But it was just kind of amazed me. Assess for history of ACEs, like, any sort of abuse. What kind of neighborhood did you grow up in? How, have you always had hypertension that you know of? What did you have to do growing up or to this time if you're not really even grown up yet? Because we're seeing more and more hypertension in adolescents and younger. Assess for current stressors. Diet, like, which we would do as a standard of care anyway. Assessing for tobacco, drugs, alcohol. Educate the need to control the hypertension. Like, why are we controlling hypertension and diabetes? What are we looking at long term? And assess their understanding of the disease and desire to make a change. I would also advocate for frequent follow-up, especially for the first 6 months to a year. Just to kind of get them back in there as often as possible. I kind of, from what I've seen, you could schedule 3 appointments and some of these patients would maybe make 1. So if you can kind of get them in there a couple of times, you want to say, I'm going to see you 4 times in the next 6 months, and you see them twice or once, then at least we're seeing them something. Social services or some sort of something to kind of get that insurance medication assistance, therapy, and I'm talking like mental therapy, like psychiatry, things like that, or even just somebody to talk to that's maybe trained in something like this to talk about stress, depression, the previous ACEs that they've had to endure, and ways to deal with these stressors, because they're not going to go away. They're always going to be there. Some stresses, and being able to deal with it and is probably a great start in helping with some of the hypertension. Local health resources for lifestyle and exercise changes. Unfortunately, the YMCA in South Bend is closing down, but I know they've had programs where we have overweight children from low-income families we can send for like camps, then they can go and actually work out. The Croc Center being another one that I just didn't list. So things like that to help with, to have a place to exercise if they happen to have the time. Diet modification, frequent follow-up, like I said. Goals, so we're going to adherence to medication if we can. And if they're not, why are we not doing the medication? Steady modification and diet. It's not all going to happen overnight. It's going to have to happen slowly. Steady increase in physical activity. So maybe walking a half an hour a week and then walking an hour a week. Measurable weight reduction in obese patients, and then reported reduction in stress related to living situation, disease, work, family over the time. And then, of course, another measurable goals are decrease in hemoglobin A1C and decrease in blood pressure, if that's what we're managing. Who's to be included? So we're going to use some sort of the live long program is what I called it. Some sort of tool to go through and figure out who could be included in these things. And you can kind of read through here. I'm kind of running out of time here. So follow up on blood pressures, point of care screening, maybe in the home or in a community setting, meetings with social services or somebody to identify government resources or other resources out there, not necessarily just government. Sorry that I put that. Therapy sessions to help to teach skills to deal with the stress. Community-based healthcare workers to do the home evaluation to maybe really look at what's in the home that could be changed that's causing some of these things. There's some things that can be fixed up, and can we get some help for them to help them fix those up? Education geared toward the community programs available. Group sessions, I think getting people together, kind of helping each other, and then also just getting them involved in the community as much as possible. Rationale for this program, again, large number of minorities have hypertension and diabetes. Cardiovascular disease is killing people. We know that. Large number of uninsured low-income minorities. Many people in this community utilize emergency department, which we don't. It costs more, and it's not the continuity of care is not there. I think I'm about running out of